Good evening. So who here has a physician that knows their name? So raise your hand if you have a physician who knows your name. Well, that's good. Those of you who raised your hand have a 19% greater chance of surviving this year. I'm really sorry for the other people in the room, but that's the way it goes. So you can ask yourself, well, why is it if a physician knows your name, you're going to survive longer? Well, if they know your name, they may know the medications you're on and check if there's any lethal interactions. They also may know the chronic diseases that you have and call you up when you need to have a follow-up to test you, to follow those problems that might affect both your quality of life and your length of life. They also might even follow the major tests that you might have and get back to you if there's something that needs to be followed up upon. So we have a problem in the U.S., which is our healthcare system is broken. It's expensive but not effective. We're number one in cost, and America loves to be number one, but we're 37th in outcomes. This mismatch is a basic problem for not just healthcare, but the American way. More is not better. More is not better. Now, where do you get that more is not better? If you go to a store and you buy a new pair of shoes or a new car, if you spend more, you expect something better. But in terms of healthcare, the more you spend, it turns out the worse your healthcare is, and that's as individuals, as a population, as regions. We have a big problem. Our healthcare system is often called a non-system. It's like a house that's been blown apart. It's in pieces with wreckage everywhere. Nothing is communicated, nothing is connected, nothing's integrated. Nothing is working to know that the right hand knows what the left hand's doing, whether it's primary, secondary, tertiary care. I'll give an example. Two biggest hospitals in Rhode Island, quarter-mile apart. If you have a test in one of them and you're in the other one and you're on the healthcare team and want to get the result, it's quicker for you to run over than to get it by telephone, fax, or electronically. And also we have problems that we don't have the right workforce. We have, unfortunately, too big of a ratio of specialists to generalists. We have all kinds of new people that need to be connectors in the healthcare system that don't exist. And we have lots of perverse incentives economically. What do I mean by that? Well, if you go to see your primary care doctor, have a comprehensive visit, $100. If you go to see the same doctor, but in the emergency room, $1,000. If you happen to be admitted to the hospital, $10,000. Now, you don't need a degree in economics to know that you can't make up $10,000 with $100 bills. So whether it's every hospital in Rhode Island or across the country, they've expanded their emergency rooms, which are the way that they both bring in that $1,000 and also move to the $10,000. But it's time to ask, is that what we really need? Where do we go from here? Well, let's make it real with three people. I'll call them the Jones family. They're not an actual family, but the three cases are real. So let's start with Sam Jones, 59-year-old grandfather. Health has been getting worse over the past few years. His heart's not working so well. He gets congestive heart failure, which means he fills up with fluid. His economics haven't been so good. He's been out of work, doesn't have many savings, and he takes Lasix, which is a water pill, helps him to urinate, get rid of that fluid, but he hasn't been able to afford the $4 that it would take to buy that. So unfortunately, nobody was checking in on him too much. He got sick one day, it just couldn't breathe, got short of breath, ended up in the emergency room, was admitted to our community hospital, was 10 days there, had a pretty rocky course, made it out though, $30,000 bill, back at his house. When he was back at his house, however, he still couldn't afford the $4 for that medication, that simple water pill. And so what happened 1 week later? Readmission. But this time he had to call 911, get the rescue to get him, take him back to the same hospital, back to the emergency room. This time he ended up for 1 week in the intensive care unit, 2 weeks on the floor in the regular medical surgical ward, $70,000, and a lot of suffering. So for want of $4 for a water pill, $100,000 is spent by society, and this 59-year-old gentleman suffers. He has a daughter named Melissa. She's 32 years old. When she got the call the second time that he was in the ICU, that it wasn't clear if he was going to make it, she got in her car, rushed over, hit a telephone pole. She was taken to the very same hospital, to the emergency department. She wasn't wearing her seatbelt, and she crashed into the steering wheel. They put her in, did a CT scan, didn't have any bleeds, things were fine. She was able to be discharged, go visit her father. But when they reread the test, the imaging test, they noticed that there might be a lump or something in her right breast. Unfortunately, they didn't have the name of her primary care physician, and they had mixed up some of the numbers in her telephone call, and they didn't have a mechanism for follow-up anyway. So she didn't get that diagnosis, she didn't get warned, and a year later she showed up in her primary care office with a much larger mass, metastatic disease, right mastectomy, chemotherapy. So for want of a PCP, a primary care physician's phone number or her phone number, she ended up with surgery, chemotherapy, suffering. She has a daughter, Melanie, who's 10 years old. Now, Melanie has a little bit of asthma, usually not a problem, but the people who take care of her grandfather and her mother, weren't able to be there. When her mother was able to kind of get her for a yearly flu shot, her pediatrician family medicine office was closed. Also, they weren't able to get her there for her usual checkups, so she didn't get refills on her medication. And one day she got the flu, had an exacerbation, a worsening of her asthma, and she ended up in the hospital. Her mother wasn't able to stay with her. She was already traumatized by her mother's absences, so she had a rocky course. 2 days was admitted to the hospital. So for want of preventive care, a flu shot, and some preventive medication, she ended up hospitalized, traumatized. Well, all parts of the system are broken, but I'm a family doctor in primary care. And family medicine, general practice, primary care, it's actually an American invention, started in the colonies. And what's happened over the course of time is that about every 30 years, the United States wakes up and says, oh my God, we don't have enough primary care doctors. There's no one to take care of people in the suburbs, in the inner city, in the rural areas, and they get frantic. Well, we got frantic about 10 years ago. So frantic that finally all the primary care disciplines, the internists, the pediatricians, the family doctors got together and said, we can't let things go on this way. So what's primary care? Well, Institute of Medicine says the provision of integrated, accessible health care by clinicians who are accountable for addressing a large majority of personal health needs. So undifferentiated problems, we'll take care of you. Sustained partnership about relationship with patients, practicing the context of family and community. So we came together as disciplines. We said we have to change what we're doing, and the result was the patient-centered medical home. We went from the old model, and the old model is that care happens when you're in front of the doctor. You're on the outside, you come into the clinic, you see the doctor. Now, that would be fine, except it turns out the average American was in front of their family practice or primary care doctor for 2 hours a year. So what happens the other 8,763 hours? So what's in the new model? The new model says, first of all, it's a partnership, and first of all, it's a team, and it's about communication. It's about access to care. So being able to reach someone not just 9 to 5, but on the evening and the weekends. It's about patient engagement, not being acted upon, but being a partner in care. It's about clinical information systems. That information should flow from primary to secondary to tertiary and be available through portals to the patients. It's about care coordination, having new roles and new people who help to make sure people get the care where they need it, when they need it. It's about team care, which is a skill we don't have, and about patient feedback so that patients can provide input on what the system can do to help them. So it's about empowered patients working with coordinated, integrated teams. It's about not just primary care, but creating medical neighborhoods where specialists, hospitalists, nursing homes, home care services, all in the community, all working together in a nice symphony, improving health and well-being. So let's go back to the Joneses. What would have happened in this new healthcare system? Well, Sam Jones would have had a nurse care manager who would have called him every month or so to make sure he got his medications. A social worker would make sure that he could actually afford them. He'd probably have a fairly fancy little scale in his house that sent the information on his weights to his nurse care manager and primary care physician so they would know when he was beginning to fill up with fluid and wouldn't have to be hospitalized even the first time. What would happen to Melissa? Well, she wouldn't be in the accident in the first place, but if she had had that CAT scan and had the mass detected or even a question, that information would flow seamlessly to her primary care physician. It also might flow to her through a portal or directly. How about her daughter? Well, she would get that flu shot at a time and place that was convenient to the family and would have help in getting the medications she needed to manage her asthma as an outpatient and allow her to have a healthy, happy childhood. So finally, we have a big challenge because this is a big step to take towards the patient-centered medical home. We don't exactly have the workforce that we need. We need to train more generalists and slightly few specialists, so it's a change in ratio. We need to come up with new roles. Who are these nurse care managers and how are they trained and what do they do? We probably need some patient navigators to help patients figure out how to work through electronically and get to where they want to go. We need community outreach workers who are coordinated and can work with the whole teams. And we need to be able to activate patients to take advantage of it. We need lots of new skills. We don't train people how to work in teams. We don't train people how to use IT effectively. So it's a challenge to all of us to change our educational system for all the health disciplines and to rework how we work together. So it's really going from compliance to cooperation to collaboration to building community. The goal, which is really at the top, it's time to work smarter, not harder. So remember that 19% greater chance of survival I talked about if just a physician knows your name? Well, what would happen if a whole team not just knew your name, but knew your problems, knew how to work with you, and were coordinated to help you in your health and well-being? Well, you might live forever. Well, I don't know if you're going to live forever, but certainly health and well-being would be accomplished. So what's the bottom line here? Working smarter, not harder, team-based care, new models, improving the experience of care, the cost of care to get better health, lower costs, better outcomes, not just for the 19%, but for everybody. Thank you.